Morning.
Good morning, Chris. Margarita Nordin here.
Hi, Margarita. Nice to see you. Nice to meet you.
Nice to see you.
How are you keeping?
Fine, thank you. Where are you in the world? I know you're in UK, but about where?
Yeah. On the south coast, just along from Brighton.
Oh, okay.
About 70 miles from London. Yeah, lovely.
Yes. Yeah, it's lovely.
And it's snowing today.
Yeah.
It is, yeah. Snowing in April, but there we are.
Yes.
It's all right. Whereabouts are you?
I'm in France, in the middle of France, in the Loire Valley.
Oh, lovely. Yeah, beautiful.
And we have no snow and springtime.
Nice. Yeah, I think I prefer yours.
Yeah. It's coming towards you soon. We hope.
Fingers crossed.
Yeah. This is exciting. We have more than, I think, 450 registrants. That doesn't mean that all will participate.
That's great.
Yeah.
Brilliant. Exciting.
Thank you for participating. It's an honor.
Well, thanks for asking me. Yeah, thank you. It's I'm looking forward to it.
It's really Caroline and Oine and Anisha, who is behind a lot of the organization.
Yeah, that's great. Yeah, I've met Caroline. I've spoken to Caroline.
Okay.
Cool.
Here.
Hello.
Hello.
Morning.
All right. Morning.
Thanks for all the work you have done with Caroline.
Yeah, I think Caroline is an extra pair of hands.
Yeah. No, the first one is always the most, but you've done a wonderful work.
Mm. How are you, Chris? It's nice to have you today as well.
Yeah, thanks very much. Yeah, thanks for asking me. I'm good, thanks. Yeah, I think.
Yeah.
Kind of ready.
I attended a few of your courses recently.
Have you?
Very good. Yeah.
You're a glutton for punishment.
Apparently. I'm just wondering, I have a few of the polls done, and do I need to be made a co-host just to input them? Or are they already inputted? Rajani.
Hi, good afternoon, everybody.
How are you?
Mercer, this is Rajni Mullar Patel.
Hi, nice to meet you.
Nice to meet you, and thank you so much for agreeing to do this today for us.
Yeah, no worries. Thank you for asking me.
Thank you. Hi, Margarita. Good afternoon.
Hi, Rajani.
And I'm trying to get your name, Oina. Is that right?
Anya.
Anya.
Yeah.
Sorry.
No.
Right. You had a question, Anya.
Just about the polls. I'm wondering, do I have to be made a co-host just to input them?
Right. Just a second. The seven of us, that is yourself, Margarita, Chris, Raghu Verma, myself, Anisha, and the host, the IT guy. We are on the panel. So we are the panelists. So we are able to mute, unmute, turn our videos on, off, share our screens. And the rest all are going to be the participants, which means that they will remain on mute at all times, just to avoid any microphones left on or things like that. And if they need to ask a question, obviously that would be in the chat box, and we can unmute them at that stage. So does that help?
But Rajani, we are only taking written questions in the question and answer box,
Yes,
right?
yes. So which is why we do not need to unmute anybody. And that's what I said, that all the participants will continue to remain mute throughout the session. Does that help?
You should have access to the question and answer, Oina.
Yes, Oina, you will have access to the question because you are on the panelist mode.
Yeah, and I do have that, but the polls usually comes up at the bottom as well, but I think you have to be a host to see that.
All right, okay.
Or a co-host.
Fine. Let me have a word with this guy. If you just give me a second.
Sorry. Hi.
Hey, Caroline.
Hi, Caroline.
Okay.
Hi, Caroline.
We all good to go?
Can I just check whether I share my screen? Just make sure you can see it. Is that right?
Rajani has to give you the
Hi, Caroline.
Hello.
Hi. So you and Anya will very soon receive access to become co-hosts.
Yeah, I have that here.
Yeah.
Rajani, can you show Chris how to share the screen? You are the host now.
I think I can share from my end, Margarita.
Yes, he can share. Yeah.
Can I just run it by you just to make sure it's working all right? Is that right?
Please. Yeah.
Thanks.
Would you prefer the text or post the exercises out? Perfect. Awesome. Yeah, no, that's perfect. Yeah, I can send that on. And if you have a computer, there's a link there. If you use the link, very simple. Turn it on over back. It's an exercise for shoulder to shoulder roll.
Okay.
Is that all right? But little often is key. If there's any major issues, my name is Padraig, and you can ring back on the number. But I think it should settle down well. Over it. The reason we picked 6 weeks before any had the part of the starts to form. So before that, like in the same like extra stuff.
Does that come up as the whole slide?
I think you still have to play from the beginning. If you say play from the beginning, it'll come up.
That's on there. Does that not come up on yours?
It's coming up as if it's not. We can still see the small slides at the side.
Okay.
You have to put in presentation mode. On the button, go by 61%. That's this one, right?
From there? Is that better?
No.
No.
Okay.
I think if you go down to the bottom, there might be there's the little icons at the bottom, Chris.
Yeah, I've got slideshow. That's the one I clicked on. That's not.
Oh, use present.
Any good there now? No. Is that the same?
Yeah.
That hasn't changed at all.
No.
Okay. Okay.
So the address we have is 15 Donamead Avenue, Donamead, Dublin 613. Is that all right? Okay, Deirdre, listen, have a good week. Take care. Bye.
I think at the bottom of the PowerPoint, there should be icons as well that might allow you to.
Rajani, is there somebody from the IT present at the moment that's running the
Yeah.
the webinar? Yeah, just because inputting the polls, you actually have to be the host, not the co-host. So I'm just sending them on the questions in the chat. I'm wondering if they can embed them then into the webinar.
Right. All right.
I sent a message there, but I'm just wondering, is there definitely somebody kind of on the other end of it?
There's
yeah.
somebody just in the adjoining room. So Anil Khandare is the name of the IT team member who's with us, and he's just next door, so I can ask him to.
Yeah, I've just sent him a message, so maybe he will get that, but
yeah,
just in case.
So from the sharing here, you can just see everything. You can't see the slideshow per se. You can see the slide and slides down the side. Is that right?
Yeah.
Anil.
So I've gone on from beginning, and I've gone from down at the bottom the slide show, but that doesn't. Let me just. Try again. Is that back on the same view?
Yeah.
Okay. Any suggestions?
Go into
you may try to put it on presentation mode before you open it up on Zoom. That sometimes works.
Okay. So.
So there's something went in the chat there, Chris. Double click on the icon left to 61%.
Yep. That just brings me up to there, which that's what I've done already.
Okay.
Does that bring you up? That doesn't change it.
We can just see your tagline now. We can't see the slides.
No.
Dear, this is calling again here. Just because I'm going to be off in a few weeks' time, I might just schedule that appointment now. Is that okay? Would Thursday the 29th, so we're talking about two and a half weeks. Thursday the 29th of April at 2 o'clock work all right for you? Okay, perfect. I'll put that in and we'll give you a call back. Is the home number the best one to get you on? Perfect. And those exercises are already gone out. Okay, great stuff. Bye now.
Lots of people joining.
Can you see that now?
No, we can. No, we can just see your list of your files.
And now you can see the list of slides. But if I click on the slide show, that doesn't change it. Is that right?
No, it's still as was.
I'm just wondering, Chris, because whenever this has happened in the past, if you reckon emailing us a copy of your slides, or either to Caroline or somebody who is able to play it, do you think that might work as a backup option? Good afternoon, Dr. Raghuvatma.
Yeah, I've emailed a copy this morning.
All right. Okay.
Of this version.
Right. So you've emailed it to Caroline. Caroline, do you have that email?
Do I have that copy? Yes. Do you want me to send them on to you?
Yes, please. Just in case
I'll do that now, yeah.
we could, and you could just guide us to move to the next slide. Good afternoon, Dr. Verma.
Anita should have a copy of them as well, actually.
Right. All right.
Anisha's got, yeah, both got a copy.
Yeah, let me ask.
I'll just send them back.
Am I audible?
Good afternoon.
Yeah.
Good afternoon. Am I audible? I'm audible. Good enough?
Yes, yes. Do you want to just share your screen and check whether it all
I'll
works?
check once. Yeah, 1 second.
Yeah,
1 second.
thanks. And in the meanwhile, Chris, I am downloading your presentation.
It's the one that Caroline sent you this morning.
Yes.
The latest one. Yeah.
Yeah.
Okay, thanks.
Is my screen visible?
Yes, the screen is visible. And do
So
you want to go on the slideshow mode?
Yeah, I'll do that. I'll just kind of, just to check it.
Yeah, sure.
So it's seen?
Yes, brilliant.
Okay.
And so now, so it all works, which is great. Now, Chris, what we are going to do is play your slides from here. Do you think we should do that? Shall we open that screen?
Hello, Dr. Nordin.
Hi, Dr. Varma. So
Long
nice to
time.
see you.
Long time since we met.
2 years.
Yeah, I know.
2 years of COVID.
I know. It's kept all of us indoors, I guess. Basically.
Yes.
Just 1 second. Get the light on.
Dr. Varma, while we are waiting, can I say that you are still involved in a search in Gachiholi?
Yeah, it is. It is. Yes. We just had the
Is that
last
okay?
camp. Yeah, the last camp was in March, the first week. It was almost after an year because the COVID crisis did catch up eventually with the rural population. And we had almost about, I think this time we did about 21 surgeries, but that was a cumulative effect of having not gone for a while. But yes, the rural population did have, Nagpur now I think is an epicenter. I mean, there are so many cases there. So it's but obvious that Gadchiroli will come in the bracket, but I think yes.
Okay, thank you so much. I just wanted to make sure so that I didn't, because it's such an important project.
I know it is. It is.
Yes.
Rajani, can I just check you're going to run the slides? Is that the plan? And then I'll speak to them.
Yeah, can you see the full slide screen now?
I can, yeah.
Are you happy with this, Chris?
Yeah, I can do it from this end if I just ask you to advance the slides. Is that okay?
Yes, please. So you just say when you want the slide to be moved to the next slide.
Perfect.
And Anisha will do that. So this is being shared from Anisha's screen.
Yeah. Can you just scroll through a couple just to make sure it's the right one? Yep, that's fine. No worries. That's perfect.
Yeah,
Thank you.
We'll just run through all if you want.
No, that's fine. Thank you.
That's fine? All right.
Yeah,
So,
great. Thank you.
Yeah.
Thanks very much.
Thanks. Thank you. Margarita, should we start?
Perfect.
Anil? Good morning, good afternoon to each one of you from different parts of India, UK, France, and I can see Cambodia. On behalf of the family of MGM Institute of Health Sciences, led by the Chancellor Sri Kamal Kishore Kadam and Vice Chancellor Professor Shashank Darvi, and the family of World Spine Care, presided by Dr. Scott Holman and Adam Wilkie, I'm delighted to welcome each one of you with a namaskar, hello, to our first spine webinar of the series. Our webinar series is a joint collaboration between World Spine Care and MGM School of Physiotherapy, MGM Institute of Health Sciences. And the timing is so perfect. Just when we welcome the National Commission for Allied and Healthcare Professions Act 2021 in India, we intend to refresh, refine our insight in evidence-based conservative spine care for first contact practice. This year, our webinar series will focus on the evidence-based assessment and treatment of cervical spine pathologies. In today's webinar, we have two excellent speakers who will present the evidence for screening for serious pathology of the cervical spine. The next webinar in the series will follow in July 2021, and we will keep you posted on the date, which will focus on evidence-based rehabilitation of neck pain. My name is Rajani Mullar-Patan, along with a vibrant team of faculty of MGM School of Physiotherapy at MGM Institute of Health Sciences in Navi Mumbai. We strive to train physiotherapists with global competencies and those who are locally aware of the problems. MGM IHS is a deemed to be university working towards the mission of delivering quality healthcare to all sections of the society with compassion and benevolence at an affordable cost. It's accredited with grade A by the National Assessment and Accreditation Council of India. Today, I'm pleased to moderate this webinar with Professor Dr. Margarita Norden, who's committed to evidence-based care for spine disorders, transfer of knowledge to different cultures and adaptation, and develop guidelines into health promoting policies. So the platform is over to you now, Dr. Norden, to share a bit more about yourself and the World Spine Care.
Thank you, Professor Mullar-Patan. And Rajani is a colleague and a dear friend. And it has just been a pleasure to work with MGM and World Spine Care together in several projects. I am Margarita Norden, as Rajani says, and I am the past president of World Spine Care Europe and the vice president of World Spine Care Global. And I am also a professor at New York University in New York at the departments of orthopedic surgery and environmental medicine. World Spine Care is 12 on its 13th year of existence. It's a global charity on mission to improve lives in underserved communities. We aim to create a world in which everybody or everyone has access to the highest spine care possible. And we currently operate in 5 countries, such as India, of course, with MGM, Botswana, Dominican Republic, Canada, and also Ghana. Before I hand over to our eloquent speakers, just a few housekeeping measures. Please remind to mute your lines, and if you have questions and answers, please put them in the question and answer box, not in the chat box, in the question and answer box. And these questions will be reviewed by our excellent team around us during the presentation. And the recording of this panel presentation will be made available soon after this presentation is over. And we also broadcasting this live presentation via Facebook. So having said that, please, the word goes back to Rajani and to introduction of our speakers. Over to you, Rajani.
We extend a warm welcome to both our guest speakers for today, Chris Mercer, who's a consultant physiotherapist in the NHS UK, and Dr. Prasad Verma, consultant spine surgeon in Mumbai in India, who have kindly taken their time out of their busy schedules to be with us here today to speak on screening for serious pathology of the cervical spine. May I introduce to you Chris Mercer, a consultant musculoskeletal physiotherapist at Western Sussex Hospitals in NHS Trust in the UK. Chris Mercer has a keen interest in serious spinal pathology and spinal masqueraders, teaching widely on both topics as well as spinal radiology. Chris is currently involved with an international team of researchers looking to develop a clinical reasoning framework for spinal red flags. He's the national lead for the primary care and the community care work stream of the NHS England Musculoskeletal Best Health Program. So over to you, Chris Mercer. Thank you so much for agreeing to be a part of this webinar today.
Thanks, Rajani, and thanks to MGM and World Spine Care for inviting me to speak to you today. I'm going to talk about the framework that we did on developing the framework, and talk through the process, talk through some of the challenges around red flags, and how we identify them. So I'll just wait for the slides to go to the first slide. Okay. Thanks, Anisha, nearly there. Okay, so that's me. I work in the NHS. I run the spinal clinic for the hospital here with a team of advanced practice physiotherapists working closely with our surgical and medical colleagues. Next slide, please. So this is the framework that we produced in July of last year with the team there. So I've put that up really to recognise that this was a big team effort to produce this framework. And with some really fantastic researchers and clinicians on the group. Next slide, please. So we came together because there was a challenge, and there was a challenge for us that we'd seen in clinical practice in identifying red flags and identifying them at an early stage. What we want to do is to pick up serious pathology, but pick it up early, because we know that if we pick it up early, we can make a difference. So the size of the challenge, we thought we'd be able to quantify that fairly easily, but it's not as easy as you'd think in the evidence. But if next slide, please. Some of the data here is around the 4 most common lumbar spine pathologies, so cord recliner, fracture, malignancy, and infection. And those are the the main pathologies we focused on in the study. So you can see the estimated incidence of these is relatively low in terms of population numbers. So if you think about 0.04 or up to 0.4% of people presenting with cord requiner, or up to 5% of patients presenting with fracture with low back pain. Actually, the percentages are small, but the reality is the numbers are quite big. Once you see, if you see 100 patients a week and 5% of those may have fracture, or 0.4% of that number of patients may have cord requiner, or may have malignancy, or may have infection, then you're starting to, these are individuals we're talking about, not statistics. So the numbers add up very quickly. In our trust, we see 13,000 new patients a year. So, we're looking at probably 4 or 5 cases of serious pathology a month. So that's 1 a week. So we have to be on the ball and pick these up. Next slide, please. So there's lots of research around red flags, or lots of comment around red flags, and these papers go back to the early 2010s, 2013, and they question the role of red flags in identifying malignancy or fracture or serious pathology. So here we've got malignancy, we've got fracture over here, we've got infection over here, because they're not sensitive and they're not specific. We have whole lists of red flags, but what we've started to do in the last 10 years is question how useful they are in identifying serious pathology. Next, please. So I'm going to look at 3 papers. So if you can just press three times, move us on 3 times. Next slide. Next slide, please, Anisha. Thank you. Yep, lovely. So these 3 papers. So this one here, this pre-Kumar paper, looked at incidents with low back pain patients, and they took 10,000 patients from. Oh, sorry, can you go back, Anisha? Sorry, and forward now one. Oh, forward one again. So the pre-Kumar paper took 10,000 patients who had low back pain and screened them against the known red flags in the guidelines. And what they found was that, and they looked specifically at night pain. 96% of patients who had night pain had no serious pathology. But I guess more concerningly, more worryingly, was 64% of those with a spinal malignancy had no red flag symptoms from the recognized list of red flags. If we go to the next slide. Similarly, with fracture screening tools, this paper looked at nearly 80 guidelines from 28 countries, identified some separate red flags to identify kind of risk of fracture and those likely to fracture, and narrowed it down to a small number of previous fracture, older age group, previous trauma or high trauma, and osteoporosis as risk factors. And those have been reproduced in several research papers over the years. But what they looked at with these studies was to see whether the recommendations were based in research, and only 9 out of the 78 were based in research. The rest were based on expert opinion or had borrowed from other guidelines. And similarly, only 9 out of the 78 had produced information on these guidelines around diagnostic accuracy of these risk factors and clinical presentation. Next slide, please. Similarly, with infection, this is a paper by Laura Finucane, one of the co-authors on the framework. They were looking for information around spinal infection and predictors in spinal infection, but were unable to find good high-quality papers around spinal infection. So rather than doing a systematic review, did a descriptive review of 40 papers and identified several clinical features and kind of determinants, they called them, or risk factors for infection. So the 3 things that came up in terms of infection were pain, fever, and neurological dysfunction being the unholy triad, but only around 50% of patients will present with that. And for risk factors, immunosuppression, a history of TB, diabetes, and IV drug abuse. So immunosuppression covered patients who were either on cancer therapy, immunosuppressed because of corticosteroids, or immunosuppressed for a whole host of reasons. People on rheumatological drugs as well. Next slide, please. And even with things like cauda because of the rarity, because of the incidence being difficult, this 19% figure here about clinical symptoms matching scan findings, again, highlights the difficulty we have even in identifying serious pathology when we think it's an easy thing to find, like cauda equina. So we have a big challenge. Next slide, please. And that challenge extends into the cervical spine. The first few slides have shown you predominantly evidence around lumbar spine, but in the cervical spine, there's even less evidence and even less robust evidence. We would think that the evidence would be robust in the lumbar spine, but it's not. And in the cervical spine, it's probably less so. And if we're thinking about serious pathology in the cervical spine, we're going to think about instability. We're going to think about cervical myelopathy, which Dr. Dharma will talk about in detail later. We're going to talk about infection and fracture. Okay, so in terms of instability, 0.6% of people presenting to chiropractors and osteopaths and physios with neck pain are likely to have or potentially going to have instability. So again, it's small numbers. And as a result of that, with this second paper, there's lots of delay to diagnosis or misdiagnosis, and clearly the consequences of misdiagnosis for cervical instability could potentially be very serious for the patient. We're talking about significant neurological deficit at best, and more severe consequences at worst. Next slide, please. In terms of infections, again, they're rare. Cervical infections account for 5 up to 20% of spinal infections, but spinal infections are still a rarity. So out of a rare condition, cervical spine infection is even rarer. Okay, so we're looking for needles in haystacks, but we need to find the needles. In terms of cervical myelopathy, again, it's a rare condition. 1.6 to 4.4 per 100,000 population. And again, we need to make sure that we can find these patients and we can identify them early. We know with cervical myelopathy that around 50% of patients with cord compression on scans don't have symptoms. The vast and won't go on to develop symptoms. So there's a significant number of patients don't develop symptoms. So again, it makes it hard for us to identify those patients that need intervention. Next slide, please. The other thing that we're concerned about from a physiotherapy point of view is cervical artery dysfunction. And there's been a lot in the literature over the years about whether we're able to identify patients with cervical artery dysfunction and whether we should proceed with manual and manipulative therapy for those patients. And we've tried with various physical tests to identify those patients, but we know those tests aren't valid or reliable. They're not good predictors, which is what this international framework, the second paper on here, showed, and recommends that we don't do physical testing, but we do significant history taking. We take a good cardiovascular history, but we do know there's a risk associated with manual therapy. We just can't quantify it. Next slide, please. So this was our challenge when coming to develop the framework. The framework is really, it was designed by clinicians and developed by clinicians with the help of expert researchers to actually try and support clinicians in clinical decision making. It's not a research tool, it's a clinical decision support tool, and that's how we've kind of framed the framework. So next slide, please. And next slide. So what did we do? So we divided the process into 5 phases. First one was a review of the evidence as it stood around the 4 serious pathologies of cauda equina, fracture, malignancy, cauda equina, fracture, malignancy, and infection. Sorry. So we looked at the current evidence. Where there wasn't evidence, we looked at doing the papers, which I talked about with Laura's paper. We then identified risk factors, signs and symptoms, and sent those out to 100 experts from 19 countries around the world using a Delphi-type consensus methodology. And they rated risk factors and signs and symptoms as to whether they thought they were important or not. We then collated those and developed the draft framework, which then went out to peer review again from a large body of expert reviewers from across the world and also patients. We then revised the final document and published the framework in July last year. Next slide, please. So what do we do with the, we tried to look at the evidence, look at the clinical profile of the patient, and then in the middle section here of this Venn diagram to try and estimate the level of concern that the physio should have, or the clinician should have around that patient. So that was based on how common the pathologies were, how many red flags they had, how many red flags in combination they had, whether the symptoms were progressing or not, and making a decision about how urgent they should be. Next slide, please. So we came up with this kind of traffic light type symptom. So green is no concerning features, red, concerning features, and in these categories, decided whether it was okay to continue to treat the patient, whether it was okay to continue to treat but monitor. And with the two boxes on the right, these are around those with concerning features, potential serious pathology, but the amber to the red is the decision about whether to act immediately or whether it's okay to watchful wait. So that's how we've kind of devised the framework. Next slide, please. And this pathway kind of explains what to do and how we kind of see it working with a clinical reasoning model. Is if a patient presents with no concerning features, they follow the green line, they get treatment as planned. If treatment progresses, then patient discharged as per normal. If they have some yellow features, sort of some slightly concerning features, but not really, then we would watchfully wait, treat the patient, see how they progressed. If they got better, fine. If they didn't, then we'd move them to the red pathway. And the red pathway is around, does this patient need moving on to another expert, or do they need further investigation with imaging or blood tests or whatever? Next slide, please. So the way we do, I'll talk you through now the different categories in the framework. So what we did, this is for fracture, and this item was sent out to 28 experts around fracture. So these were a range of physiotherapists and medics and rheumatologists, and they reviewed 27 items that have been identified. Next slide, please. And we divide it up into risk factors as the first category. So these are some of the risk factors for fracture. So down the left-hand column, you've got the risk, so history of osteoporosis, steroid use, etc. And then in the next column, the context. Well, why is that important? So we've kind of explained that with some evidence behind them. In the third column, there are questions for clinicians to ask. So this is about going deeper than just a list of red flags. This is about asking in-depth questions about what, do you have osteoporosis? Has you got a family history? Going a lot deeper. And then on the last two columns, this is related to the person's response. If they have no family history, no osteoporotic risk factors, no previous fractures, then they would have a low clinical suspicion. If they had the opposite, then there'll be a high clinical suspicion. So this is just to help categorize those patients who may present with certain features, but we can then categorize them into low risk or high risk. Next slide, please. And next slide again. We then went from risk factors to the symptoms. So in terms of symptoms, how is this person presenting? If they have thoracic pain, then we would ask, we would look at these and say, well, yes, we know that most spinal fractures are in the thoracic spine, about 10% in the cervical spine, 20% in the lumbar spine. And then we would ask some more further questions and then put them in these high and low category boxes. So after the symptoms, we went on to signs. Next slide, please. So these are the clinical tests we would do or for patients that we thought these are the clinical examinations that came up as being important. So spinal tenderness, neurological signs, deformity or contusion or abrasion, and then the questions we would ask related to those. Next slide, please. And then finally, we put what sort of imaging, what are the next steps for these patients and what's an appropriate form of imaging. So what X-rays are good for, what MRI is good for, what CT is good for. Okay, so it's followed through in terms of almost following through your clinical reasoning. That's how we've designed the document. Next slide, please. And then we put in some case studies. So these cases are really to try and help people with their clinical reasoning. So we put clinical case studies that have different categories of risk. So in this example was a 35-year-old man presenting with thoracic pain after lifting a heavy bag of concrete. You know, what are his risk factors? Well, he's lifted something heavy, but he's under 65. He's got no family history, no steroid use, no fractures, no excessive alcohol use, minimal smoking. So his risk factor is very low. So we put him in the green box and said, okay, he's okay to treat and we'll see how he goes. Whereas in the next category, next slide, please. This is a different scenario with a 78-year-old woman presenting with spinal pain, history of fractures previously, had an early menopause and started her periods late, a late menarche, so has significant risk factors. So age and sex, pain's worsening, early menopause, late menarche, and pain when lying down, and a history of fractures. So this patient needed further investigation. Okay, so that's how we've put it in the framework in these cases. Next slide, please. So it's a whistle-stop tour, but it's really just to say, you know, we've developed this tool really as a working document. This is work in progress. So we've put it out there for comment. It is predominantly around lumbar spine, but actually the issues around infection, the issues around fracture, the issues around malignancy apply exactly to the cervical spine as well. But we know that the incidence of these pathologies in the cervical spine is less than in the thoracic and lumbar spine, but the principles in this document are exactly the same. What it's highlighted is that more research is required, as ever, always the case. But from the work, we know that serious pathology is rare in percentage terms, but frequently seen. And that sounds like a bit counterintuitive. But as I said earlier, you know, each one of these cases relates to one person, and we don't want these people to present late with their serious pathology because they have a worse outcome and they're much harder to treat. Identification of these patients is through detailed history taking, detailed examination, and good clinical reasoning. We cannot follow the lists of red flags. We have to do in-depth examination. You need to have clear pathways for managing these patients, and those pathways need good mentorship and good governance. So myself, Laura, Sue Greenhouse, who we work with, are all consultant physios, all experienced, but we use each other as mentors. And we all have mentors in the medical and surgical world to help. So it's about getting a team around you, I think. Next slide, please. Just to say a big thank you in various different languages. I hope yours is in there. I think that's it from me. So thank you all. Thanks for your time. Thanks for your attention.
Thank you, Chris Mercer, for this excellent presentations. We are gathering all our question and answer in the Q&A box. So please, for the participants, send your questions in the Q&A box. We will go directly to our second speaker, who will talk about indication for spinal surgery with a particular focus on degenerative cervical myelopathy. It is a distinct honor and pleasure to introduce Dr. Raghu Prasad Varma, a consultant spine surgeon working at the Hiranandani Hospital in Mumbai, and way beyond that also. Dr. Varma has completed multiple spine fellowship and worked in the UK, Germany, USA, and Singapore. Dr. Verma is also very active with the WHO Center Search in Gadchirole in the state of Maharashtra, and is the president of the Spine Foundation in Mumbai, and is really has focused a lot on how to serve the underserved people. Dr. Verma is also the faculty at multiple regional and national spinal meetings, and is a reviewer of Journal on Bone and Joint Surgery, and has multiple spine-related publication and awards to your excellent credits. So it's all yours, Dr. Verma. Most welcome.
Yeah, I hope all of you can see my screen.
Yes, it's perfect.
Sure. Thank you, Dr. Noordin. Thank you, Dr. Rajni, and the entire World Spine Forum to give me an opportunity to speak. Just as an extension to what Dr. Mercer said, we have a bigger hair sac in India and bigger needles and more needles to fudge. So obviously our numbers stand out. But what are we going to talk about here is indications for surgery in a cervical spine pathology. Yeah, so we all know a good surgeon is the one who knows how to operate. A better surgeon is the one who knows when to operate. And rather, the best surgeon is the one who knows when not to operate. And I guess this is the basis on which this talk is going to go ahead. So let's look at indications and let's look at some case-based scenarios. Might make it a little more easier to handle. And we look at some evidence, protocol, and pathologies. So why not start with trauma, which is what Dr. Mercer did stress upon. And let's look at some case scenarios. So this one's a male 28-year-old road traffic accident. Mind you, he's a shopkeeper by profession. And he has got about 14 people who work under him. So he just supervises. And when he had the fall, he had nil neuro. In fact, he just had some mild neck pain. But one of these, the orthopedic surgeons who saw him eventually did do an X-ray. You can make out a fracture C2 vertebrae there, which led to doing a CT, which obviously showed far more comminuted fractures, which you can see here. Now, he's an intelligent guy, so we discussed with him what are the options of treatment. And we said there's this long drawn conservative treatment and the quick fix surgical treatment. However, this is not the best fractures to fix. It's not that easy as we think it is. So I was pretty praying to God that he would say conservative, and rightfully so, he agreed on it. So we put him through a complete bed rest, avoid rotations with a Philadelphia collar, 4 weeks of rest, no tractions, and kept frequently following up. The patient was pretty compliant, and we had a wonderful rehabilitation physiotherapist unit who worked on exercises pretty early once the pain was better. And at 18 weeks, there was no instability at flexion extensions, complete healing of the comminuted fractures. And incidentally, he came last week with some other patient, and he had an excellent 12-year follow-up result, which is done very well, remarkably to what it could have been. So what's the lesson learned here? A properly monitored conservative trial after explaining all the risks and benefits to the patient and ensuring a critical regular follow-up helps us achieve a good result. Now, is this a norm? Now, I go to a hospital with Dr. Rajni will concur with, which is the Mathadi Hospital. They are the manual laborers who actually kind of lift 60 to 80 kilograms, as you can see it in that statue portrayed there. And he had a fall with a heavy weight of the head, and you can actually classically see a C2 mildly displaced fracture. Though not well educated, he was very, very clear about what he wanted. He said, I can't be resting at 3 months because that will put a lot of financial strain on my family. And the fact that he had to go back to doing that kind of work eventually because he couldn't do anything else. So we then, in this case, fixed the spine with an anti-rodontoid screw with a long-term good result. Or a 41-year-old IT professional, road traffic accident. And obviously all of you all will agree that this one is a displaced fracture. It's like a fracture dislocation with comminution at the pars, at the multiple levels. No way that we could have done it without a surgical option. So what are the lessons we learned in these ones? A significant neurology or a clinico-radiological instability in a high-demand occupation, especially in a young patient, warrants surgery. Let's go a little subaxial now. Now, this is a lady who was actually cleaning up the fan in her home, and a stool slipped and she fell. She's a homemaker. She actually was nil neuro, but had a cervical fracture subluxation. Actually, she waited 2 weeks applying some local treatments, presuming it was just a neck strain. But eventually it was investigated and we found a subtle fascial fracture subluxation. We went through the same discussion that we did with the shopkeeper, and she also agreed on the conservative trial. Mind you, at 6 months, she had full functional range of motion. We could agree it's a little malunited. We could also agree that it is still sublux, but probably united in subluxation. And at 8-year follow-up, she has no issues. And she never had to take a pain medication at all for the last 2-3 years for any actual cervical pain. What is the lesson learned here? That a radiological instability in a low demand young patient, I'm not saying a homemaker's job is low demand, but the comparison to the manual laborer, you put him into the low demand, doesn't warrant surgery at all. And there could be enough in the literature which justifies an intervention for such cases. But let's take every case independently. Would that hold in the same stead for this group? This is a fracture dislocation, bifacetal, in an, again, a laborer in whom there was nil neuro. Mind you, the neurological criteria goes out of this. If you look at it, you could see that this had to be done with a proper anterior and posterior full Monty reduction with decompression, because he had to go back to that kind of job profile eventually. A few points on the whiplash injuries. The 68-year-old man who actually fell as he walked out of his washroom and slipped over the mat, very classical in the older age group. He actually came with grade 2 neurology in both the upper and lower limbs. There was significant myelomalacia, as you can see here in the MRI. But what made a difference was there was an inherent cervical canal stenosis. We offered him surgery. There were compression that we could see, and at 1.5 years, so I think 12 months, we got an MR done, which showed two things: well decompressed cord. At the same time, the whole myelomalacic area got confined to a certain small segment there. This patient almost recovered completely with a little residual hand and bladder issues, but was mobile and functional. Does that hold true in the second case? This one also had a whiplash kind of an injury, 56-year-old, significant neurology, but there was no instability and no compression. If you look flexion extension views in this, there is no instability. Even in the MRI, there was a significant myelomalacic patch, as you can see there. But as we serially saw them at 6 and 12 months, it had resolved by itself. And this patient, mind you, had functional full activity as a 56-year-old once he recovered in about 6 to 8 weeks with good rehab. So all neurological deficits do not warrant surgery. But even when there is nil neurology, an unstable spine, which needs an identification very early with compression and justifiable instability, needs stabilization and decompression. Infection, enough and more in our scenario in India. And if you look at these kind of MRIs of a lady at 28 years of age who came with early quadriparesis, with severe destruction of a vertebrae with epidural and, as we see, prevertebral infection, she was actually sent to us for surgery, but we conserved her when the diagnosis was tuberculosis. Mind you, this was the time we weren't doing CT-guided biopsies or taking samples, but empirical treatment at 3 years had completely full range of movement with an excellent result. So all neurological deficits may not warrant surgery in infection. Why? Because tuberculosis is a medical disease and spine is a manifestation of a medical disease. If you treat the cause, the effect gets better by itself. And is it one anecdotal case? We've had the opportunity to present it in world forums where multiple horrendous looking MRIs in this fashion completely heal with pure conservative medical treatment. This lady is one I wouldn't forget. This lady was sent to us for surgery, actually admitted her. We got some IV steroids going till such time she was being investigated to go ahead for surgery. By the 3rd day of the steroid, her neuro had recovered. We spoke to the relatives and see, you've got two options. One is this long drawn out rest, antituberculous treatment and wait and watch, or we do surgery, which might rehabilitate you faster. She agreed on the fact that we will wait and watch. And mind you, this is full recovery. She's now a mother of 2 kids and functionally doing everything that needs to. So what's the lesson? Does a radiological destruction in the MRI or an X-ray warrant surgical intervention? No. The same theory that it's a medical disease and you're treating the spinal manifestations hold true. But is that the norm? Look at this one, a 39-year-old male with progressive neuro. Mind you, he was diagnosed later as a multi-resident tuberculosis. No way am I being able to wait here and watch till he becomes a complete neurodeficit individual. We had to intervene and go ahead and do something for this at that stage. So a progressively worsening neurology, I think these words are important, progressively worsening neurology needs surgical intervention because we can't wait till the spinal manifestations become irreversible as we treat it medically. A couple of examples of tumor. This is one of my prize patients, a 52-year-old man, debilitating neck pain, nil neurology, kept talking about pain to an extent. If you look at the right-hand corner, there is a psychiatrist prescription. He was sent to a psychiatrist thinking that he has something like a psychosomatic disorder. A simple X-ray at that point showed an osteolytic lesion that you can see here in the C2 spinous process. It was biopsied and sent, and it came as plasmacytoma. Mind you, completely treated with just adjuvant focal radiotherapy. He didn't need any surgery at all. So having this clue of looking at something intractable, which is not getting better with time, has to be kept in the mind as we treat them as medical professionals. So primary diagnosis is a key. What about this lady? This lady actually was losing weight, appetite going down, suddenly came up with quadriparesis with severe onset neck pain of a short duration, a collapsed vertebrae. In this patient, we couldn't wait for a diagnosis. So what did we do? We took a sample, decompressed, sent it, came out to be an adenocarcinoma. Because it was an adenocarcinoma, we went back and looked at a primary and found a CA lung with mets. This lady did well for a long period until she died a couple of years ago because of the primary lesion. So in tumor, the lesson is progressive worsening in neurology, especially in a patient who's either under treatment or an unknown primary requires surgical intervention. Mind you, these are the group you will have to keep their survival index in mind. If the primary pathology is not going to let the patient survive for more than 6 months, your heroic surgery is of no consequence. Also, they are medically not the best because of comorbidities. Keep this in mind as we talk about decided surgery. A prize patient of mine in the deformity section. This is a guy with long-standing kyphotic spine, severe degenerative changes, fascial arthropathies. You can see the level of kyphosis, intractable axial pains, and he had pain right, he had had treatment right from A to Z, as we call it, from Ayurveda to Zumba. Everything was done for him, but he was very unhappy, even blocks, pain management. But in an X-ray intraction, we could see that it was a correctable deformity, and we offered him surgery. With much discussions and deliberations, we did it, and he's now about 6 years follow-up where surgery did help. So in deformities, mind you, progressive disability has to be kept in mind. In this group too, comorbidities and risk of complications are very high. What about the myelopathics? This is a topic of interest, so I kept it for the last. Let's put the degenerative into two groups, the myelopathic group and the radiculopathic group. Now, this is one of my interesting patients, a 49-year-old laborer, cervical disc, acute onset with myelopathy. He came with almost grade 2 power. And because he had a bad experience in one of his relatives' surgery, was hell-bent on not getting it operated. And you can look at the amount of MRI compression there in both the axials and the sag. And interestingly, just as a follow-up, because I had follow-up of this patient, we took his MRI at about 1.5 years, and I saw complete resolution of that myelopathy. Mind you, it's the same person's MRI. Couldn't believe it. But what was the endpoint? He had significant residual disabilities with hand function. His bladder insufficiency persisted to an extent that he was taken off the rota as a laborer and has not worked for the last 8 years. Is it worth it? So in a myelopathic like this one, a driver, 39-year-old with similar kind of presentation, decompressing the nerve, stabilizing the spine is probably the right way to go. Though this might look very anecdotal and very forthright, I still believe that the myelopathy group with long tract signs should not be overlooked. However minimal the scenarios that they escaped surgery, operate unless proved otherwise. Mind you, in India, they come very late in their presentation. The role of the rehabilitation unit is immense here. And I have to stress this because post-operatively, after we do the job, what lets these patients go back to functional efficiency is this multidisciplinary approach along with the rehab group. We have a surgical classification, not so important. What it essentially talks about is if you have an anterior compression, stay anterior. If you have posterior compression, stay posterior. But what about the radiculopathy group? Here I'm radically going the other way. Conserve unless proved otherwise. So a dentist, 24-year-old, came with right trapezial pain, had some inadvertent traction done or some procedures done, which led to worsening of the symptoms and a radiculopathy. You can clearly see a left-sided posterolateral foraminal disc there, triceps weakness, pain inhibited, actually was sent to us considering surgery. We discussed it extensively with the patient and said, why operate? Why not conserve? So in an acute posterolateral disc with radiculopathy with no significant neurology, stay conservative in its approach. So rest the NSAIDs, the gabapentins, the oral steroids, the collar, traction, epidural steroids. So one of the commonest questions that's put forth to me, what would you do if you have an acute onset pain, patient wants to go back to work at the earliest? Mind you, if you have a proper documented MR and a proper documented radiological investigations which match with the clinical picture, a root block or an epidural works wonders. Mind you, no needles unless you have a diagnosis. So no freehand needles to be put in. And is it true? Anecdotal? No, we've got enough and more of such kind of discs in the foraminal, completely regress in 6 months with a very good conservative trial. This one, very interesting, 36-year-old female. She was a banker with a C6 radiculopathy, with a mild C6 weakness. You can see a disc at the C5-6 there. She was actually sent for considering surgery. We discussed and said, why not conserve? Because she was already getting better with treatment. But 3 years later, the same lady had a fall and a C7 radiculopathy at a level with significant triceps weakness. And you can see here how the C5-6 is nicely resolved, but the C6-7's become a large disc here. Same patient, similar pathology. But fortunately, the physiotherapist who treated her the last time was the first line of defense for this patient. And she thought that there was something not good in the triceps weakness. Send it to me. And obviously, there was this huge foraminal disc there. And this time, obviously, we had to operate because the disability index was very significant. Last few cases here. An IT professional, very high demand, a man who's gone through the Google and all the other access of social media and otherwise for treatment protocols. It was very clear that he didn't want compromise in movement. He was a generally very good, stable spine, as we can see there. And we did what we call as a ACDR or anterior cervical disc replacement with good follow-up for 5 years. Is it true for only this group? I think the most important group are the professional level sportsmen, and we've had the fortunate opportunity to treat a few of them. This is a pistol shooter, and if you know the pistol shooter, they have the classical posts in which they kind of need to rotate laterally onto one side. He was just unable to hold on to his gun. You actually see whenever he right lateral rotated, this impingement that was happening here was significant enough to disable him. So obviously, in a high demand sport like that, where they had to work and train extensively, surgery was a good option. What about a national level wrestler here? He didn't have a problem entire day, but at a certain part of his Greco-Roman wrestling style, when the neck went into extension, he would have this sudden onset weakness in the hand. And he went back to training post-surgery in a fusion in this case, because a wrestler was no way going to have a disc replacement, kind of looking at the job profile. So we choose your intervention depending upon the job profile of the patient. The last but not the least, a 34-year cricket test batsman, left-sided neck pain, batting stance was getting painful. We thought we were looking at something like that, the shooter. But here it was classical fascicle arthropathy. And did we operate him? No way. We just gave him some fascicle injections and put him on a rotator stabilization exercises. So the lessons learned in degenerative spine is that's a battle between natural history and the disability of the patient. If the natural history is going to be quick enough to prevent too much disability, stay conservative. But if the disability index is so much that it's taking too long for the natural history to take over, we might have to change our plan. So what's in it for you as an audience? I think the red flags to look for is neurological weakness, especially progressive, irrespective of the pathology, becomes an indication to seek a specialist opinion. Intractable pain not responding to primary treatment, just like that plasmacytoma of the C2 spinous, needs to be investigated. Age, occupation, medical status, patient's expectations need to be kept in the loop. And the natural history of the pathology, if known, will make it easier to treat. As I wind up, Remember that the ability to perform a surgery doesn't take away the indications to perform it. Opt conservative, but not at the cost of patient's disability and expectation. Stay by the principles. Most times they give you end results. Medical practice is an amalgamation of predominant evidence peppered with a little experience. Literature justifies almost everything, but be case specific when you look at our patients. Multidisciplinary approach is the need of the hour. Clinico-radiological correlations with the knowledge of the pathology helps. And last but not least, keep your patient in the loop, because in these eras of medical legal issues, let them know at each stage why you're doing a certain part of the treatment protocol. Thank you. Thank you very much.
Thank you so much for this excellent presentation. We learned a lot and many practical tips. So we're now going over to the discussion, which is going to be led by Dr. Rajani Mulapatan. So please go ahead, Rajani.
Thank you, Margarita. We have some questions in the question and answers chat box, which I have sent it to these speakers. But here are a few questions that we had from earlier. I think the first question, since we have both of you speakers here, is when, as a physiotherapist, would you recommend the patient to see a surgeon when the patient seeks treatment with you for cervical pain? So this is a question going to Chris Mercer. So Chris, when do you think that you need to refer the patient to a surgeon?
Yeah, thanks. I think this could equally go to Dr. Varma, because I think his summary slides actually answer that question really nicely. You know, the things that I would be looking for were either people that presented with unusual symptoms, things that don't fit. Wouldn't necessarily go to a surgeon, but might want further investigation. But certainly worsening neurological deficit, worsening pain that's not responding to sensible treatment. Those would be my main criteria, really. I think it's very much based on patient presentation. So if it fits a recognised pattern, you'd be more comfortable and you might be happy to watchfully wait. If it's outside of that or it's a deteriorating picture, then you move the patient on more rapidly.
Right. And when you say a sensible treatment, what would you quickly summarize as sensible evidence-based treatment?
Evidence-based, now you're asking, but certainly in terms of advice, in terms of maybe manual therapy as part of a package of care, and that package would include some exercise-based, some rehabilitation-based processes, but also sensible evidence-based use of analgesics.
Right. Thank you, Chris. And now here is a question to both of you. What will be your preferred course of action when a patient presents with an agonizing cervical radiculopathy and must work, particularly a manual worker, a laborer? Because we know how much, particularly in the low-income countries, that it becomes difficult for these people to take time off work because there is no paid time off work for them.
So if you want me to answer that, obviously, we've had great experiences looking at the entire spectrum of our population. I mean, we've had patients who would wait 3-6 months and not want anything to be done. And the other group, like you said, for whom the daily wage, I mean, what he earns today is what the family feeds on the same evening. So in those contexts, when you talk about, you have to treat them separately. Now, over the period of so many years, we know that the oral medication, even the intravenous medications, take a little while. Not that they're not ready to accept it, but sometimes at the end of the day, if they fail, we found if you keep all the modalities, which looks the ultrasound, the short waves, the TENS, the IFTs, everything put together, a quick fix solution. If that's your question to me, I would look at doing what we call as a root block or a facetal block or something which works. Now, we know that it works for a short period of time, but that short period of time might be good enough for all the other modalities to fall in place. But mind you, like I put it in my slides, no needles go into a human body unless you have evidence. We've had patients who've come with pain management and pain blocks done and actually induce and overlook a diagnosis which shouldn't have missed. So the concept is that the moment you know that you want to put in a needle, you'll be pretty sure that you have enough evidence to prove that you're not missing out on anything that's pathologically wrong. But in most scenarios, the block necessarily doesn't solve the problem, as we all know. I mean, we have enough evidence to show, but it buys you time so that all the other things let you fall back in place. And I think that's what some of these low-income group patients ask for, because they don't want to be off work too long.
And
Yeah,
how?
I'd agree
sorry.
in terms of. Sorry, I'd just agree in terms of not sticking a needle in unless you know what you're sticking it into. I think it's about, it depends on the cause of the acute radiculopathy. Once you know the cause, then you can make a sensible decision.
I have a comment, Rajani, if I may.
Yeah, please, please.
And this is to both our excellent presenters. There was a very good award paper from Sweden last year saying that the time of a conservative and eventually going to surgery for radiculopathy, at least for lumbar radiculopathy, should be done before 3 months if there was no improvement. And my question to both of you, to my knowledge, there has been no paper on this concerning cervical radiculopathy. But when is the time for the optimal treatment to collaborate between, physios, surgeons, osteopaths, chiropractors, whomever is taking care from conservative to more invasive?
I think the three. You're right. I'm not aware of good papers to support the timelines, but I think it would be reasonable to extrapolate from the lumbar spine data to say 3 months is a reasonable period. It's a reasonable kind of natural healing time. So I think I would extrapolate from the lumbar spine data.
I would agree. I mean, I would say timeframes aside, I think you would give them optimum time. The only difference in the cervical spine group, if I might, is that the myelopathy component of the disc is not so much there in the lumbar spine. It's a pure radiculopathy-oriented causative effect. Some of them present initially with the radiculopathy and then kind of tip over into a myelopathy in a short period of time. Not that I've seen too many, but I've seen a few in which the whole concentration was to treat the radiculopathy symptoms, and they've worsened under treatment. But if I keep those aside, I think I would agree that 6 to 8 weeks or extrapolate 3 months is a period of time to shift from conservative to a.
Thank you. And just one more question that we have here. After the surgery, when would you recommend the patient with a cervical radiculopathy to seek care from a physiotherapist? So how early do you think, or late do you think physiotherapy
Immediately.
Immediately.
For that matter, immediately. Because I think what we need to understand in both the radiculopathy and the myelopathy group is that you've taken away the causative part of it. But the neural rehabilitation, which is obviously with the help of the musculoskeletal and otherwise rehabilitation, has a tremendous role, especially in the myelopathy group, because just taking the pressure of the cord and leaving him with a grade 2-3 power is not what we are doing this for. And I think we've been so aggressive in some of the myelopathics that we made them actually sit the next day bedside. Obviously pain dependent, and you can't be have somebody who's in miserable in pain trying to be too aggressive with them. But the moment the pain would permit, the exercises would start. Obviously, you are not going to do the neck exercises day one. You're going to do the upper limb, the lower limb, and all those, spirometry, especially the older group in the myelopathy. Radiculopathy, obviously, that's not the issue. But if you look at the exercise regimen, start straight away, especially for the upper and lower limb. The neck exercise is something I start about 3 to 4 weeks after the surgery, especially with a controlled, supervised manner, because if you just leave them away with it, they might do something untoward. But I think the physio role starts pretty early.
Yeah. And ideally, it could start pre-surgery. These patients are generally generally deconditioned. You know, they've had pain for a long time and loss of function for a long time. So there's lots we can do, you know, before and immediately afterwards. I'd agree.
Absolutely.
Yeah, and thank you. There's another interesting question that comes from the audience is to say that in cases where post-surgery rehabilitation takes as much equal time as conservative management, owing to age and comorbidities, what should be our plan of action? So I think what the audience is trying to ask is where the time would be the same for conservative treatment or for post-surgery rehab to finally achieve the expected outcome. What should be the preferred plan of action?
I think it depends on, one, the patient expectation, what the patient wants, what the patient needs to do, and also, I guess, on the risk of deterioration without doing surgery. So it comes back to what Dr. Varma was saying about the indications for surgery. I think really, you know, it's that, you know, if we leave this patient, are they likely to progress and get worse, even if we're going to put them out of action for, you know, 3 months. And have it go through rehabilitation to end up at the same point. Actually, this is about maybe longer term preventative.
I'd agree. And I think that comes back to the very theme of the webinar today about screening for serious spine pathologies, because you do not want an undesired outcome in the long run. And there's another question which talks about more related to the mechanical loading of the cervical spine from a very friend, Dr. Dhruv Mehta, and he wants to know what is the permissible limit of taking loads on the head by kilograms. So I think what he's intending to ask is, what is it that beyond which can be considered as harmful in terms of mechanical loading?
I can't answer that one.
Yeah.
Me too, Dr. Mehta. I could say that. I mean, I would say whatever is comfortable for the patient. I know of some of them who've actually done amazing kind of activity post-op. And I remember going to this area where the laborers work. I mean, I had the opportunity to go for something else. And I saw one of my post-ops trying to lift about some 80 kilogram, sack off the truck and put it into the go-down. And I was like sweating it out, looking at what he's going to do with my lumbar fusion. But he did it with absolute finesse. I think if as part of the job profile or otherwise, their musculoskeletal profile is good, the muscles well toned, they kind of recuperate so much easier to doing what they want to do. We always try to equate it with us, our so-called, what we call as indoor, easy chair kind of job profiles, and kind of extrapolate whether we'll be able to do it. But I don't think there is an upper load or an upper limit I can remember. I think
you can rehabilitate people to adapt to those loads. So yeah, if somebody needs to be carrying, shifting 80 kilo bags, that's not beyond the realm. One of our physiotherapists came third in the world's strongest man, and he was lifting 180 kilos. But it took him a long time to get to that stage. But he trained to do it. So I think it's around being specific with the functional rehab, I guess.
I do agree with what you're both saying, but we have very few longitudinal studies when these people who have carried a lot of loads on their heads, for example, if they fare well when they get older. We do know from construction workers who lift a lot, but not necessarily always put it, and those are from westernized country, that the neck and shoulder parts, they really have a lot of pain when they retire after they stop working. So I think we have to be careful because we don't really have the data.
I agree.
Right. And I see that there are a few more questions, but we are running off the time span, so we can have these questions answered later. So, Margarita, do we have any more time to answer any further questions?
We are out of time.
Yes, precisely.
Unfortunately, but what I can say is that if we ask our wonderful group to copy the questions, we will then try to have them answered on the website.
Sure, sure.
Yes,
Yep,
and
no
in
problem.
the
No
meanwhile,
problem.
what I'm also doing is copying these questions to our speakers. So if they had a moment to answer in the chat box, that would help as well. So that brings us to the end of our session. And this has been a brilliant session by both our opening batsmen, as we would call them. Cricket is so popular in India as well as in England. So a very big thank you to Chris Mercer and Dr. Raghu Prasad Verma. We are extremely grateful to you for your time and for this presentation today, and also to take the questions at the end of it. And we would also like to take on behalf of the World Spine Care and NGM Institute of Health Sciences, an opportunity to thank all those who helped us to organize this webinar, particularly our MGM IHS WSC webinar series organization team, Caroline Trainer, Anisha Gulati, Aina again, and our MGM IHS IT team, which is led by Mr. Anil Khandare. So a big thank you to all of you. And before we conclude, a reminder that we'll be sending all attendees a recording of this webinar, as well as the details for the second webinar in the series, which is in July 2021. Please watch out for the date. We will send those out as announcements. And we'll also send you a feedback survey, and would be very grateful if you could complete this for us to inform us, also to inform you of the future webinars. So once again, thank you very much for joining us today. Do visit the website of mgmuhs.com and World Spine Care org to learn a little more about both the organizations and their efforts to keep conservative spine care going and getting more and more trained for evidence-based care. So a big thank you to all of you once again.
Thank you.
Thank you,
Thank
both
you.
the speakers, and thank you to the audience.
Thank you so much.
Thank you,
Thanks all.
Margarita. Thank you. Bye-bye.
Bye-bye.
Bye bye.
Bye-bye.